Good morning, everyone. Welcome. Are you ready? Here's our patient. I like pictures. I like lectures to be like a children's book where we have photo after photo of every step of the way. This is our patient, Mark. It's the first time I've ever met Mark. He comes in. I love patients like Mark because Mark says, I know it's time. And he knows it is. You know it is. And you're looking at Mark, and you know, what goes on in our minds is, I need to get these impressions or these scans. I need to get a cone beam. I need to work out a financial arrangement. The hygienist is calling me. I got to go in the other room. When do I have time on my schedule to get this in? And we have all these things that are going on in our mind that happen when we're in a busy practice. And then, of course, Mark has what's going on in his mind. And we're going to talk about how we should talk to these people so that our case acceptance increases. But what I want to talk with you guys primarily is, how do we treatment plan these patients? And I'm going to give you some information, and then I would like us to treatment plan him together. So it would start with identifying the patient's condition, and what we would find is, based on your training, that you would see things completely differently than everyone else in the room. You know, of course, the endodontist is probably saying, I can save several of those teeth. You know, the restorative dentist is saying, for what reason? You know, what could I then do with those? And so we want to talk about treatment planning very large cases. And, you know, if you put in a single implant and a mandibular first molar on a patient and you give them a restoration that lasts, let's say, even a lifetime, you've done this amazing service, but you haven't really changed how the world will see them and maybe how they will see themselves once you have completed therapy. When you do full arch implant supported prosthetics and full mouth, you are giving them an entire new identity. And it's so fun to have these courses because when we're done with these people, they look entirely different. And it's very fun for you and I to have that impact on individuals. And so maybe what we would do initially is we would start to look at his bone structure. So we get a CBCT. And we evaluate that and we look at it, and I'm going to say a certain phrase to you over and over this weekend, and it's going to go exactly like this, because it's the exact same phrase I say to the patient when I sit them down in my consultation room, give them a cup of coffee, pull these exact same images up on the TV that I have sitting in front of them, and I would say to Mark, hey, Mark, when you look at these images, tell me what you see. Now, I'm very deliberate in that verbiage because it's non-threatening. I'm simply asking him to look at his own images and tell me what he sees. And when we would run study clubs, we would do the same thing to each individual in the room. Okay, everyone please be quiet. Let's let the oral surgeon tell us what they see. All right, so when you look at Mark, tell me what you see. You can say anything. Caries, gross caries, a lot of decay, bone loss, missing teeth. I mean, he's hanging on to that right central hump. And what is it, by the way? Right? It's an implant. So let me give you a little more information. And we need to talk about how we were taught to treatment plan patients in dental school versus how we maybe should be treatment planning patients. And we're going to get into that in great detail. But here's his profile. And you and I know that if we look at glabella coming straight down on that profile, that we don't necessarily want their teeth proclined beyond that. Okay? So he's out a little bit forward. His scan, he's missing the majority of his posterior teeth. What else do you think is going on here? When you see the anteriors proclined with spaces between them, what do you think? An airway issue? Why? A tongue thrust. You got it. Here's the pano derived from the CBCT. And what do we call this image? This is his lip at rest position. We want to talk about this because this is our starting point, what you'll call tooth display in repose. And we know based on age how much of that central incisor should be showing, of the maxillary central incisor. And you'll notice he's not showing it at all. And so when they're not showing anything at all when they do this, and here would be my instructions to Mark. Mark, I'd like you to lick your lips, relax, let your lips touch, but don't let your back teeth touch. and then just let your mandible hang like this. And I want to see how much of his maxillary central incisal edge position relative to face shows. And the minute I don't see any of it, I'm going to grab a measuring device of some sort, and I want to know how far negative he is. And you're going to notice he's about a -2. His right side, his left side, and his occlusal views. We're all in agreement that it's a terminal dentition and everything's coming out. So his RBH, his residual bone height from the crest of the ridge to the floor of the sinus in the posterior maxilla is nil. Well, let's talk about Mark in general and his whole mouth. What do we have to be cautious of? Let's start in the maxilla because this is a good view to discuss it. So if all of his teeth are coming out, we want to keep the implants probably anterior to that unless we're going to do bilateral sinus lifts, which is always an option. And then we have his incisive canal, which may or may not come into play. Is there anything else we're necessarily concerned about? The nasal floor, maybe. Anything else? Not really. Okay, what about in his mandible? Okay, we have the nerve in the posterior. And then anterior to the mental foramen, let's say that we go 3 millimeters in case the nerve comes and then loops back and exits the foramen. Is there much that we have to worry about? Maybe some terminal branches of a lingual artery that we can sometimes identify if we're right in the midline area. But other than that, not so much. If we're in the posterior mandible, maybe a lingual fossa, just based on his bone structure, and we'll look at that. And we're going to do Mark together, of course. And here's his radiographs. And I like to ask dentists, if you just met Mark, you'd never seen or spoken to him before in your life, he schedules an appointment in your practice, you gathered that information, those photos, that cone beam, those radiographs, how much dentistry would you present to him and what fee at the first appointment? I don't know if there's a right or wrong answer, but I'm going to tell you what I would do. I would present all of it. I'm going to sit him down. I'm going to show everything. I'm going to tell him exactly what I want to do, and I'm going to tell him exactly how much it's going to cost at the first time I meet him. Because what else would I do? Where does our relationship go from there? Sometimes, as dentists, we want people to what? Like us. Like us. And I'm here to hold your feet to the fire and say, I bet the people that have said something to you at some point in your life that you didn't really necessarily accept well when you first heard it might even have hurt your feelings a little bit, but actually later on had a bigger influence on your behavior. But as a young dentist and as someone based on what phase of dentistry you're in, you tend to want people to like you because if you feel like if they like you, they'll stay with you. And if they stay with you and they get to know you for a while, and maybe you've taken out the one that's kind of hurting at this period of time, and you did a perfectly painless injection that then they'll see, and then you'll build some trust and some value and build the relationship, then you'll tell them the whole story. I have found that comes back to bite me every single time. Because they may not be a patient like Mark, they might be a patient with a lot of tooth wear. But they fractured a cusp off of one tooth, and I say, well, let me go ahead and fix it. And then when it's like to get to know them, they're in the practice for a while, they've seen the hygienist, they see how nice all of us are. Then I'll sit them down and talk to them about the full mouth rehabilitation. And then, by the way, those restorations I've done over the last 2 years, I have to redo all of those to the new vertical with the anterior guidance. And then I box myself in and I end up saying absolutely nothing. Because I'm worried if I tell them, they're going to look at me and say, why didn't you ever tell me in the first place? So we're building a relationship from the get-go on full transparency, truth, and full disclosure. Because I'm not playing around. And I'm telling all of you, if you go into the treatment presentation with that attitude, I think your case acceptance will go up. Mark knows he has a problem, and I'm here to fix it as fast as possible for him. That's what I want to do. So just from a practice management, that's how I would manage a patient like Mark. Question to all of you is, how do I go about it? His treatment from a clinical standpoint. How do we treatment plan him? Most of us were not taught how to treatment plan full arch and full mouth dentistry in dental school. We weren't. We had to go other places to find that. So how do we do that to make sure we don't get ourselves into trouble. If you're a true clinician and a true entrepreneur, what you want to do is be able to do anything and everything you want and never have any clinical complications. Whether it's beautiful veneer cases, full mouth implant cases, you want to be able to do what you want to do. You want to be paid well for doing it. You want to have zero complications, and you want them to refer everyone they know who has worse teeth and more money to you. That's what we want, right? We all do. So how do we do it? And if I were to ask all of you, what is the major problem that big implant centers, when they initially started booming, and all of us, maybe when we first started going, what would be the major problem that we could really cause ourselves a nightmare with when we're restoring full arches with implants? They do not have the proper vertical restorative space needed, and they don't realize it until when? How about when you start to fabricate the prosthesis, but damn it, were those not the best implant or integrated implants you ever put in? Right? The implants are already in, they're already integrated, and then you get to the point of starting to fabricate the restorative prosthetic and realize, I don't have enough room. Then what do you do? So we like to say, and you're going to see it on some slides, that there is always a restorative price to pay if proper treatment planning wasn't done. You're either going to jack open the vertical dimension of occlusion, which is what you mentioned, so you over open the patient to get it, you impinge on their freeway space, which comes with a host of problems. You're going to compromise the ability to clean the prosthetic, which is going to lead to other issues. Or you're going to sacrifice on material thickness, which leads to fracture of the prosthetic. One of those. You're going to have some restorative price to pay if you didn't properly treatment plan the case. So how do we plan the case? Where does it start? Do we have a treatment planning algorithm that we could use on every single patient from this moment moving forward that would work in a sequential order every single time for every single patient? Do we? Yes, we do. Of course we do. You just have to master it. So the question is, how do we treatment plan full mouth cases? And we're going to do this one together, then we're going to come back to Mark. And we'll do Mark. I'm going to take you through this one, and I'm hopefully going to show you things in the course of this one that you can apply to Mark, and you're going to tell me how to do Mark. I will ask all of you again, my friends, when you look at this patient, what do you see? You could probably name any dental condition. All right, I heard deep bite. What does that mean? A deep bite means you have a lot of overbite, which is how much your maxillary teeth overlap the mandibular teeth. Correct? All right, so let's just identify things. That's what we mean by deep bite. So, what is the ideal bite? If these are my maxillary anterior teeth, and I bite down with my mandible, and I close, and I close, and I close, how much should I overlap? Yeah, 2. And that is how much we're overlapping. We'll call that overbite. What else? When it comes to the anterior relationship of teeth, what else we got? Overjet. If we have excess overjet, we don't know if the maxilla is too far anterior or the mandible is sitting back. So we have to identify what should be in the right place, and maybe they're class 2 and the mandible is sitting too far back and we need to bring it forward, or maybe their mandible is in the right place and we need to bring the maxilla back, but for one reason or another, they have excess overjet. Okay, so that's overjet overbite. Let's just establish that. We know we have gross caries. We have some missing teeth. Now, I want you to notice or just recognize that we're looking at a full smile. There's no retractors. Here's our maxilla, occlusal view. Would you all agree or disagree that the maxillary arch is terminal? All right, so we're all in agreement. We want to take them all out. Here's a retracted view looking in from the anterior. By the way, I haven't told you this patient's 34 years old. I'll tell you that most of the teeth probe about a 4. And the mandibular anterior teeth from second bite to second bite really don't have any caries. I think one of the second buys has some distal caries, and they all probe about a 4. So before we can begin treatment planning, we should have a good diagnosis. Can we diagnose and evaluate patients better by clinically evaluating them or by looking at photos? I'm going to tell you photos. We do several photography and videography programs where we talk about the cameras and the lenses and the flash and the images and how we set the cameras up to get the images and all these sort of things. And I teach a lot of occlusion courses and things of that nature. And I always show images, and I ask that, everyone in the audience to help me treatment plan the patient. And they all get to this, we're going to do this because of these wear facets and this, we're going to open the vertical. And everybody says, we're going to do this full mouth rehabilitation. And then I ask them, how frequently are you doing full mouth rehabilitations in private practice? And what do you think they tell me? Very rarely. Never. I'm not. And I say, why not? And they're like, well, when I look at those images, it's very evident that that's what the patient needs. And then I say to them, what? Maybe you should take your own images, because images are there to increase awareness. And whose awareness are we trying to increase? Ours, first off. Yours first to aid you in the diagnosis, and then you use the same images to help the patient understand, to increase their level of awareness in the case acceptance process. And then you bring in other patients' images who are further along in whatever disease process they have. So let's say that they have a good amount of tooth wear. I would then say, Mr. Jones, I can't tell you for certain, but if you choose not to treat this, I'm concerned in 5 to 10 years you're going to be here. And then I would show him, and I want him to grasp the concept that dental disease is in fact progressive. It's not as if you just grind your teeth when you're in law school and then one day you stop, although that could happen, but you're probably going to continue to grind, and I'm going to have less and less tooth structure to restore when we actually get there. But I could protect your teeth with something, and let me show you that patient's images after I treated him, and then let me show you a 5 to 10 year follow-up on how that patient did after his restorations were done. So that's how it all plays in with the images in terms of case acceptance. So recognize that we use our own images initially to help us understand what is going on, and then we translate that to the patient. Okay, so our awareness first, and then theirs, and then the case presentation. And I'm never ever, let me tell you what I used to do as a very young dentist. I used to bring patients in, and if I recognized that they needed a lot of dentistry, they needed occlusal therapy or full mouth dentistry, I would get alginate impressions, maybe a face bow, maybe centric relation bite records. I would take all these images. I would say to the patient, there's a lot going on. If it's okay, I'd like to reschedule you for a week out, bring you in for an hour and sit down and go over everything with you, and then give you a treatment plan. And they would say, okay. And I'd say, Mrs. Jones, I'm not going to charge you anything for that next visit. Mrs. Jones would come back. And how do you think my anxiety level was when she came back? It was actually through the roof, because the case presentation process for me, when I eliminated the patient from it entirely, and I made all the decisions, and I already worked it up on what you and I call a treatment plan. That's a list of procedures and the amount of money that costs for all those, with a number on the bottom right corner. And then I had to slide that across the table to her, and she had to look at it and say, yes, JB, I trust you. No, I don't. What are you trying to do? Buy a boat at my expense? What is all this? That's the sort of things that are going through your and I's head. Okay? However, if I take all of their images and I sit down with them and I use what I call a co-discovery, I didn't coin the term, Bob Barkley did, but a co-discovery and a co-diagnostic approach, I involve them in the process, and then all of a sudden it's me and the patient versus their condition. It's disease versus me and the patient, not me and my plan over here versus them and their pocketbook. Okay? So I involve the patient in the process, and I allow them to help come up with the treatment plan. And then I just tell them, based on what you want, this is what the cost of it would be. And I do it all with them the first visit every single time, because then it's efficient. I don't have to bring them back. I don't have to put more time on my schedule. And I involve them, and we come to a decision in terms of what we're going to do together. And I would use terminology like, well, you have some fires that I'm worried about, and there's some things in your mouth that aren't ideal. And if you say to me, Mrs. Jones, I want everything as best as it possibly could so that I prevent, other problems down the line, we would address these too. But I don't know if you're at a point in your life that you want to do that. You just let me know, because I can put plans together in different ways. That way, they're dictating where we're going with things, okay? And it doesn't produce any anxiety whatsoever. And I need you to know that I don't think I have a better case to help drive home the point of you being able to very quickly look at a patient sitting in a vertical position and understand what's happened, what's changed, because you could get yourself into big trouble right here. Huge. I'm talking you want to retire trouble. Because for the life of that patient, if you don't diagnose her correctly, you're going to have to move, because she's going to keep coming in with pride. So she's lost posterior teeth, and his comment was she doesn't have the vertical dimension of occlusion that she was born with. So that's a new term that we should give a definition to, right? And I have a question to ask the group. Is it possible for a patient to present to your office with tooth wear, but when they bite down, all of their teeth touch and everything be in the proper position relative to their face? I'm going to say no, because if the teeth have changed shape, but they touch when they bite, something's moved. If I lick my lips and I swallow and I relax and my lips are closed and my posterior teeth aren't touching, what do we call this? Where am I? I'm VDR, right? Vertical dimension at rest. Just resting, vertical dimension at rest, right here, right? Okay? Then if I occlude and I put my cusp together, where am I? Okay, I'm in MIP, so maximum intercuspation position. If I now were to take a measurement from my nose to my chin and I bite, where am I? I'm at vertical dimension of occlusion. I'm at my VDO. Okay? What is the distance between rest and occluding called? Freeway space. And how many millimeters on average is that freeway space? 2 to 4. 3. You said 3. Let's just say, for the sake of our treatment plan discussion, that our condyle has no problems, no resorption, the disc is properly aligned, and she's right in the fossa. Because she is actually. So here's the question. So remember, VDO would be a measurement from, let's say, anywhere that's fixed on my maxilla, let's just say my nose, to my chin. And so when I go to my intercostal position and we measure that, that's my VDO. If a patient comes in, worn anterior teeth, let's say good amount of wear, no posterior tooth wear, the teeth touch when they bite down, have they lost VDO? No, the anterior teeth erupted to maintain contact, but they haven't lost any vertical dimension because there's no posterior tooth wear. The teeth have compensated. The next question is it possible to have a lot of tooth wear but maintain the vertical dimension? The answer is yes, because the teeth can erupt at the same amount of time that they're wearing. The system that I'm about to teach you is called facially generating the treatment plan, and we do that by looking at their face, because the answers always live in their face, because we treatment plan patients based on tooth position relative to the face, and you can never see that looking at a radiograph, a cone beam, or models. And it's very common to be teaching occlusion courses and dentists come up to me with a set of models and say, hey, JB, can you help me treatment plan my patient? And what do the models always have? But you have to understand, you're never going to get the answer by looking at the study models or the radiographs or the scans, because the answer of where tooth positions should go lives in their face. Okay? So we need a starting point. It's always the maxillary central incisor, incisal edge position relative to their face. It's exactly how you all set up a denture. All right? So let's do one together. When I see something and I'm like, man, that just doesn't look right, put someone of the same age and same sex next to our patient and then start drawing in teeth using templates that I give all of you in our photography and our workshops. The 30-year-old, which we're dealing with here, when they go to rest, they show on average 3.3 millimeters, okay? But they have a 10.5 millimeter central incisor, and when they go to full smile, how much movement do we get in the maxillary lip? The average is 6 to 8, okay? So if we show 3 and they move 7 when they go to full smile, where does the lip rest relative to their central incisor and the facial gingival margin? Right on it. But oftentimes it's tucked right under the lip. So the question to all of you is it because she's lost vertical dimension of occlusion and she's overclosed? How would you know? You would know by looking at her face and looking at the distance between her lips. Okay, when someone is overclosed, they start to get the wrinkles, and you would look at facial thirds. So we could take a measurement from glabella to the base of the nose and to the base of the nose to the chin, and those numbers are about what? 50-50. They're 51-49. Mid-face, lower face. So we could look at that and tell if they've lost vertical dimension. And I'm going to tell you, she hasn't. So how is it possible that she has not lost vertical dimension of occlusion, but when she bites down, her posterior teeth hit her ridge on the maxillary arch? They super erupted. Now we're getting somewhere. Because what happens when teeth supra erupt? What do they bring along with them for the ride? That's right, they bring gingiva and bone. So facial gingival margin. Let's draw in our mandibular anterior tooth. We already established that this patient in an ideal scenario has about 2 millimeters of overjet and overbite. Now look at our problem on the maxillary arch. We have 100% overbite, and that's in the anterior. How are we going to fit a prosthetic in the upper arch? Because the face dictates where tooth position goes, which is the start of all of our treatment plans. Now, we know that that prosthetic needs a certain amount of space, but it starts by establishing incisal edge position in the patient's face and working apically. And how many millimeters do we need? Minimum. We need 18 millimeters from the incisal edge to the platform of the implants. Where does the facial bone live relative to teeth? So if we look at the facial gingival margin on a tooth, the bone on the facial of that tooth typically lives 3 millimeters below that. So we have a 1 millimeter connective tissue attachment, a 1 millimeter epithelial attachment, and then we have a sulcus. So that would mean her bone is right there. Her bone currently is right here. It would ideally be right here, but you and I, my friends, need 18 millimeters from here to the platform of our implant. Now, to the contrary, if we were treating just that single central, look at this patient. She has a resorptive lesion on this lateral. How much bone do we remove? None. We don't even lay a flap. We never want to lay a flap when we're trying for preservation, which is what we want. We know that the bone resorbs more the horizontal dimension from the buccal moving to the lingual whenever we take a tooth out in a human. That's what happens. But we don't want that to happen if we're trying to replace teeth as if we were never there, which is what we do in our anterior course. We spend 2 days working on this. We know we want the platform of the implant hugging the lingual or palatal wall. And in a lot of cases today, I don't even take the tooth out. I do a partial extraction therapy. Okay? Here it is 4 months post. Then I remove the bar, and I want you to look at her ridge relative to the other side. How much has it resorbed moving from the buccal to the lingual? Not much at all. Things are looking pretty good. No indentation. Okay? Then we would come back, make a screw retain provisional, and start modifying our facial gingival margin position from the healing abutment after uncovery. We add contour, screw it in, cause compression and blanching of the soft tissue, give it a few weeks, bring the patient back, modify it again until we get a facial gingival margin right where we want it. That's how we do anterior implants. That's not our patient. That's where the implant would go if we were just trying to give her natural teeth. And maybe we could, as a matter of fact. We could put the implants there and we could give her a prosthetic that is all white with no pink. But that's not a hybrid. That's a much more expensive prosthetic. We're going to do those today as well. But if we want to go with a hybrid, we need 18 and we need the implant there. So what you always do is you start by establishing tooth position relative to their face, get the incisal edge positions in the proper position, get the proper height and width ratio of the teeth that you want, and then in fact work apically. Okay? So if we're going to be treatment planning off of tooth position, let's look at it relative to the literature. All you ever have to remember is 3 millimeters at 30, and then every decade of life it gets cut in half. So here are the numbers. This is 1978, Big and Brundo. So this literature has been around for 44 years. 3 millimeters at 30, 1.5 millimeters by 40, barely 1 millimeter at 50, 0.5 millimeter at 60, and by 70, when a patient relaxes, they show no tooth position. Mandibular central incisor relative to the face. At 30 years old, they show 0.5 millimeter, and then it starts doubling every decade of life as a good rule of thumb. So if we are in the business of making patients look more youthful with our dental implant prosthetics or even our veneers, what are we typically doing? We are lengthening maxillary anterior teeth and we are shortening mandibular anterior teeth, because that's how all of us were when we were in fact younger. Here's the lifespan of a patient. 30 years old to 70. Maxillary versus mandibular. And this whole concept is what we refer to as using the patient's face to develop tooth position, which always starts with aesthetics, which is the exact opposite way that you were taught to treatment plan in dental school. All right? So facially deriving the plan, working from the top to the bottom, when you and I in school were taught to work from the bottom to the top. All right? Now, we say it starts with aesthetics because aesthetics has to do with establishing the tooth position. Okay? So we look at the height to width ratio, how much gingival display, the contour and color. Then we look at the occlusion, muscles, TMJ, group function versus canine guidance. Then what are we going to use to replace the missing teeth? Implants, bridges, veneers, crowns, PFMs, full zirconia prosthetics, acrylic hybrids, and then we look at the perio, the endo, and the oral surgery. Now, it's important that you realize the sequence of treatment planning does not dictate the sequence of treatment itself. I'm not saying do veneers on patients when they have rampant perio. That's not what I'm saying at all. I'm saying evaluate them from a facial standpoint, and then you would treat them based on urgent needs. Of course, as you and I have always learned. Everyone got it? Everyone good with that? And if we're going to be treating from the face, we have to learn how to take the images. We're big on the images here because they help you see what you couldn't see in a clinical standpoint. And so just like we have 18 radiographic images in an FMX, we have 18 photos if we want to be able to see anything skeletally that is going on. And this is what we consider our full mouth series. So we have 4 facial shots: full smile, lip at rest, profile at rest, profile at smile, full smile. This is our lip at rest position. So notice Brittany here, she's 30 years old, 3 millimeters at rest, full smile, maxillary central, unworn, well-aligned teeth, lip resting right on the gingival margin, a little bit of the tooth tucked underneath. Mirror images from the right and left, teeth apart, teeth together, anteriors with a contraster, max mandibular occlusal views, straight on in occlusion, teeth slightly apart, right and left smile, and you can almost see every surface of every tooth in the patient's mouth. Now that takes a lot of time to do, and it's something that I don't do with everybody until I know they're moving forward with treatment, and even if I need them. There might be some out of that series that I grab. Just like you, I'm in a busy practice. And then to take it to the next step, if we want to see dynamic movement, what do? We take video. So we have a camera sitting on the tripod in the studio. We want to see how lips move. We want to have fun. We want to give a patient an experience, their first visit that they've never had before, because when you do what they've never had done, they expect to hear what they've never heard. And it's all about the experience when you're doing a taste presentation. And it's extremely fun for you. It's different. And so all we have is a camera on a tripod. You just hit record, turn a few lights on, and get some dynamic facial. And we have a lot of tools today, which we are implementing more and more into everyday practice. How many of you are familiar with Ray Face? It's a facial scanner. It can take a 3D facial scan with 6 cameras in half a second. You sit the patient in front of it, you tell them to smile, they line up with the markers, and you scan them. And then you implement it right into your treatment planning software, right into exocad or 3Shape. What about mod jaw? Okay, I'm going to show you what we can do today in terms of what we refer to as the dental avatar, meaning that we can take multiple images, an intraoral scan, a cone beam, a 4D jaw tracking, and a facial scan for soft tissue, and put them all together and make a 3-dimensional moving avatar with real teeth, real bone structure, and real jaw movement. It's absolutely incredible. It's super fun. You'll notice we have an ASIGA. We do a lot of digital dentistry courses here, and we've brought everyone in terms of 3D printing, and we have print-offs, and then I photograph them and we blow them up to see which has the littlest fingerprint, and then we're into Roland milling. So here's the ray face, and I'm going to show you a quick video here. Scan bodies is a whole other conversation. It's confusing labs and dentists alike. So a half a second, we get that, which can be exported and then put into a software, and we can get this. Now this is her structures entirely. An intraoral scan, a cone beam, a CBCT, and a facial scan all merged together to treatment plan off of, to put into your treatment planning software. And it's here. So you can see how much more we can do with that as opposed to just an image. Okay? So how do we like this 30-year-old's incisal ledge position? That's right. It's right around 3 millimeters. So if we bring in our patient we're comparing to, so we set our centrals. Now, if we set our centrals on a wax rim and we set the incisal edge position right where we want in our treatment planning algorithm, and then the patient smiles and they show a lot of gum tissue, do we then intrude that tooth on the rim, or do we crown lengthen a little bit? We typically crown lengthen a little bit. We would change the height to width ratio of the tooth. You know, we have all these libraries of teeth when we set them up on, dentures. So we would give them a little bit longer of a tooth because we've already established the ideal incisal edge position. Start treatment planning on photos, and in software, you get to kind of be the creator and the architect, and all of a sudden dentistry becomes a lot more fun. You involve the team, you involve the patients, you involve the lab. You're the architect and the person who's going to carry out the construction of the project. And it motivates you and energizes you. It gets you off the PPO hamster wheel that is ruining your life. By the way, studies show that dentists like longer, skinnier centrals, and patients kind of lean over here, but we typically want to be in this 72 to 77% height to width ratio. Now, how do we know when we draw a tooth on a photo what it's going to turn out to be? So if those centrals were straight up and down in their face but off to the right or left a little bit, it's not a major flaw. How do we care about how the maxillary midline lines up with the mandibular? We don't at all. I can't tell you how many times we get cases because we have about 30 dentists that we do all their porcelain work over here, and they'll be compromised in a facial midline. So we want the two centrals on the smile to be in the middle of the face and not canted. We don't care if they line up, but they're always want us to move it one way or another to line it up with the mandibular central incisors contact point, which we never would want to do, right? We just want to make sure that they're not tilted to the left or right. All right, so here's the literature. It was done by Vince Kokich Jr., and it says a maxillary midline deviation of 4 millimeters was necessary before orthodontists rated it significantly less aesthetic. However, general dentists and lay people were unable to detect even a 4 millimeter midline deviation. So you just have to make sure you don't cant it, and you all know who is the famous crooked smile. Now, Tom's is off to his left. It's also angled to his left, and his nose goes right. So we can avoid that. Once we get the central set, we know where the laterals go, right? Size of ledge position a little shorter, gingival margin position a little shorter. Once we get the lateral set, we know where the canines go. Once we get the canine set, we can start to establish the mandibular anterior tooth position. Same process of setting the incisal ledge relative to their face. And now we would ask the patient to bite down. And what did we just create? How about vertical dimension of occlusion? Yes, the VDO. We typically think about posterior teeth dictating the vertical dimension. We're always in our treatment planning going to want to let anterior. The maxillary posterior teeth fill out the buccal corridor, follow the curvature of the lower lip, and apply for a good airway. The mandibular posterior teeth just fill in the intercuspal position. That's it. You all already know it. You just have to know what happens when somebody who starts with an ideal overjet overbite position starts doing what? What do we have an absolute epidemic of? Bruxism. Now, do they show up with an anterior open bite? They don't. They show up like this. Then they get through the enamel. The dentin wears 7 to 9 times faster. Then they show up like this, and they say, Dr. White, I'm ready for my veneers. Is it possible to have anterior tooth wear or any teeth that are worn and the patient to bite down and the teeth touch and something not have moved relative to the face? And I told you the answer was no, because when they wear, even if they have anterior tooth wear, by the way, is it possible for a patient to have more posterior tooth wear than anterior tooth wear? So there's two circumstances that patient could present with that. Anterior open bite is typically erosion or some sort of jaw joint derangement where they're only hitting on it, which we characterize as anterior open bite. Yep, you got it. So a rotation back, anterior open bite. But if they have an ideal occlusion when they start, they're of course going to ride up on their anterior teeth when they start bruxing. They're going to wear their anterior teeth. Their anterior teeth are going to erupt. And when their anterior teeth erupt, they bring bone and facial gingival margins with them. And you have a patient who shows up wanting veneers with gingival margin position in the wrong place and teeth that are wider than they should be based on the length. But the incisal edge position relative to their face might in fact be correct. So the treatment plan might include orthodontic intrusion or crown lengthening. And there's pros and cons to each of those. This is how they show up. Doc, I don't like the appearance of my teeth. They're worn in the front here. And how do you evaluate how much they have worn and how much they have erupted? Facial gingival margin position. You look at the facial gingival margin and that tells you. And if the patient shows up and says, I don't want to do ortho, you'll say, Mr. Jones, you're asking me to prep teeth that you've already prepped for me. You're going to be left with a little enamel. We know that a veneer for long-term success should be bonded to at least 50% enamel. You've already reduced a lot of it, and your veneers are going to be short, fat, and with a facial gingival margin in the wrong position. You have to understand that patients do not realize this is happening because they wear their teeth and they erupt. They wear their teeth and they erupt. When they look in the mirror, they may see the same incisal edge position relative to their face because they never pull down their lip and look in the mirror. But you pull down their lip and you take a photo and then you explain and show them the etiology of what's happened. Then they're like, oh. And you say, Mr. Jones, we need to take your teeth and put them back where they go. Then when I come in and restore them, you'll see that the 1.5 millimeters, 2 millimeters that I need to reduce for incisal clearance, you've already done it for me. And now when I restore your teeth, your gingival margin positions will be in the right place. The height to width ratio of your veneers will be ideal. And I don't have to compromise your tooth structure. We would be doing dentistry that would give you a better chance of success in terms of just, moving quickly. So here's our patient. We all agreed that she had a terminal maxillary dentition. We've now established tooth position relative to her face. Now, how are we going to fit that with her mandibular teeth there? We're going to step on the rheostat. And we're going to start doing an alveolectomy. So we have to do. Okay, but you just have to realize somebody has to understand all of this in the treatment planning process, and you need them in a vertical position, face shots, smile shots, so that you understand tooth position relative to their face, so that you get the bone out of the way to get the implants at the proper position to leave enough prosthetic space for whatever you've decided to restore the patient with. And remember, we established that the primary problem that we're having around the country is that we're not facially generating the plan and we're getting implants in and well integrated. And then when it comes to the restorative aspect of the case, we don't have the room to get it done without compromising something and paying some price for a prosthetic solution. So she's hitting on both sides, her soft tissue. Here's where we want her. And notice she doesn't have the same lip space as our patient down here on the lower. She still has a lot. So what are we going to do? We're going to cut off a lot of bone. I plastied the right side. I alveolectomy the left side. Set her anterior mandible on the table there. About 8-9 millimeters, so that I can fit the prosthetics to her face and give her teeth that are not compromising the vertical and fit her face so that, she can rejoin society. What's happening, everyone? I'm JB White. I'm at Envision Las Vegas, our beautiful facility on the west side of town. We have the most advanced digital equipment. Everyone here works in real clinical conditions on phantom heads with high speed and slow speed hand pieces, all working through the microscope. We have intraoral scanners for you. We have cone beams. We have the mod jaw. We have ray facial scanning. We can't wait to host you here at our courses starting up again in February. Check us out at Envision Las Vegas to sign up, and I look forward to seeing you soon.